Welcome to today's webinar. My name is Jim Rosenberger, Director of NISS, the National Institute of Statistical Sciences. I'm very pleased that NISS can host this 7th webinar in our joint COPSS-NISS series on COVID-19 related data science. COPSS, the Committee of Presidents of Statistical Societies, includes ASA, ENAR, IMS, Statistical Society of Canada, and WENAR. I want to thank Shi-Hong Lin, Chair of the Organizing Committee, and all who helped organize this series of webinars. And thanks to Glenn Johnson at NISS, who's providing additional support for the series. Participants are all muted, but we encourage you to put your questions during the session into the Q&A box on the bottom of your screen. Today's session was organized by Lily Zhao, University of Michigan, and will be moderated by her during the session. She's a research associate professor in the Department of Biostatistics and a member of the organizing committee representing ENAR. She will introduce our speaker, Brahmar Mukherjee, University of Michigan, and moderate the Q&A at the end of the webinar. I now turn the webinar over to Lily Zhao.
I'm actually very honored to be the moderator for today's webinar. So it is my great pleasure to introduce Brahmar Mukherjee. Brahmar is a professor and chair of Department of Biostatistics, professor of epidemiology, University of Michigan School of Public Health. And she also served as the associate director for quantitative data science, University of Michigan Rogoff Cancer Center. She's also the founding director of the University of Michigan's Summer Institute on Big Data. Her research interests include statistical methods for analysis of electronic health records, studies of gene-environment interactions, Bayesian methods. Brahmar and her team have been modeling the SARS-CoV-2 virus trajectory in India since March of last year. So today, Brahmar will talk about modeling COVID-19 outbreak in India, and she will show us how she used the statistical power to help guide the government lockdown decision in India. So for the webinar, for the first 30 minutes to 40 minutes, Brahmar will present her work, then followed by questions. So you can submit your questions anytime in the Q&A box. Okay, so now let me hand it over to Brahmar.
Thank you very much, Lily, and thanks to everyone on the COPSS-NISS organizing committee for this opportunity to present my work. So this afternoon, I want to share not just my statistical work, how I lived as a data scientist for the past 1 year. It has been truly a transformative time for me as a person and me as a data scientist, so I cannot really decouple the two. So, but before I begin, I really want to thank Professor Shi-Hong Lin. This photo was taken when we were allowed to travel and we could meet friends at conferences. And this is ISI meeting in Morocco. And Shi-Hong, under strange circumstances, is having a platter of light and candles on her head. And she has been my guiding light. And this month is Women's History Month and celebrating women, and how Shi-Hong has done her work in COVID-19. But not only that, how she has encouraged all of us to be a part of this movement as statisticians and to have a place at the table that has been truly inspiring for me. So I want to share the work of our group. And I think that this is a work that I'm presenting, but this is a team of people who came together under very challenging circumstances. We started this work, I still remember the day, because it was March 16th, the first day of the stay-at-home orders at Michigan. And I looked at the students from India around me, and they were lost. And they were thinking that, when are we going to see our parents again? And then I reached out to the international student community. They were also under the same angst and anguish. So as someone who is also sharing and wondering, when am I going to see my parents again? I wanted to repurpose their anxiety into something meaningful. And we cannot really go and work in the front line and see patients. And how can we help out as public health data scientists? So this work is really a contribution and service to the community and bringing a group together. That was really the motivation behind this work. And everything else that happened is just a byproduct of that altruistic desire. So in this group, I just want to thank everybody. And it's a composition of people from University of Connecticut, Johns Hopkins University, a large number of people from University of Michigan, Delhi School of Economics, University of Amherst, and several people that joined the group later. Before I begin, I want to spend a moment thanking all my colleagues at Michigan Medicine and elsewhere in the world who have been at the front line, really navigating this whole year. And from Detroit, Michigan to Dharavi, Mumbai, the chronicle and the sacrifice of frontline health workers has been very common. And so from last year to this year in December 14th, I was in India. When I saw these pictures on the social media of first set of healthcare workers getting vaccinated, I truly cried, because what a year it has been for the triumph of science and the role of data science in all of this. So from the agony of last March to the promises and the hope that is carried in a vial with several vaccines coming out and being rolled out all over the world. And you always hear about safety and efficacy, but I also want to show you some of the price considerations, because I'm going to talk about India, where vaccinating half of India is going to take an enormous amount of resources for the government. So price is also important, whether vaccines are affordable or not. So this slide gives a landscape. This was done in January, and this landscape is emerging, and we have lots of data coming at us about different features of the vaccine. And as these vaccines are rolled out, for example, this was a study in New England Journal of Medicine on the vaccine effectiveness in real populations studying Israel. And from personal, as you can see that after receiving the COVID vaccine, just how we are processing the data as data scientists, but also consumers of data in terms of our data digestion, data processing, and which vaccine. This has been really a personal and population story weaved together. And then this is data from University of Michigan. So this was just extracted yesterday. That this is showing you serology tests, the antibody tests that patients at Michigan are doing, and the green bars are negative tests and the red bars are positive tests. And you can see that the proportion of antibody positive tests grew incredibly as vaccination began. So this is something that I'm not going to talk about today, but the electronic health records give you real-time sense of what is happening in the population as well. So yesterday there was an article by Natalie Dean, which has all of these in Nature and her perspective on what we need to do to come together as a community to process, pull, and synthesize data, with vaccine studies being rolled out with different designs and different protocol, different inclusion and exclusion criteria, some having the new variants and some not having the new variants and real life data. So statisticians have a huge role to play, how the community synthesizes and processes data. And we have seen several examples where high profile papers have had to be retracted because we are doing science at a very rapid pace. And I'm going to come to that again. So the variants, and this slide is taken from the Twitter feed of Eric Topol, and this is a slide of the landscape of the new variants which are chasing the vaccines, and we're trying to inoculate a large number of the population so that the virus cannot mutate and morph into something more lethal and infectious. And we are worried about the vaccine efficacy because we do not have enough clinical trial data. So in this conundrum, in this moment of data, the enormous amount of data, but how to really really synthesize data for the public, we have a huge role to play. And again, my students really did all of this work. They were excited about analyzing the data from Michigan Medicine. They were interested in analyzing the data from India and other countries. And so I really want to pay my tribute to the students at Michigan who contributed to this work. So a main part of our work has been with the EHR, and where some of my more methodological research lies. But what we did for India is something quite different. And I had not done or studied infectious disease models before, we heard about the coronavirus. So when we were hearing from our colleagues in China about the Wuhan in December of 2019, when we're hearing about the outbreak in Wuhan, and they're trying to model it, and they were already developing methods and models. And I was just playing around with it because these compartmental models just seemed very interesting, non-traditional, something that we have never, I have never played with as a statistician. We start with writing down y equal to x beta, but this is a very different class of models. So I was playing with it, but I'm by no means am I an infectious disease modeler. So this is something truly we wanted to take an off-the-shelf product and then apply it to the data from India. And then it grew. So I just want to share that story. And I'm going to talk a little bit about the pre-lockdown scenario in India. India had a national lockdown in March of 2020 for 6 weeks. And then the ramifications of the lockdown, and then post-lockdown, and how this research grew. And the last part, I really want to spend about 10 minutes talking from this numerical analysis to humanitarian data science, and what we have learned, not just as scientists, but as human beings living through this unprecedented time. So as I mentioned, on March 16th, we tried to take the data from India and started our modeling. And by March 20th, we had an article, it's a Medium article, which was published on March 20th. And this article, when we wrote it, we chose Medium. And before that, I did not even have a Medium account. We chose Medium as a medium because there was no time for peer-reviewed publication. And we also instantaneously created a website. And I think this is one key message that I want to communicate today, that how important it is to actually have apps and website where people can see the data real time. And so if you are interested in our papers and software that we have produced, I strongly encourage you to visit this website, covid19.org. And so when we published the Medium article, we had no idea. And again, it was just a 30-page report published on my center's website and this Medium article where we talked about projections. And the actual paper came out in a special issue of Harvard Data Science Review. That came out in June. So, the moment would have been lost if we had waited for the peer-reviewed publications to come out. And even medRxiv and arXiv does not really transmit that well to the large population in India who we were trying to draw their attention to. So this was the data when on March 16th, when we started modeling this pandemic. And this will seem so minuscule in today's terms that India had a total number of cases of 536 cases and 11 deaths. So just to give you a sense of magnitude, at one point of time in September, India was recording about 100,000 cases every day. So this is when we started. So that's why I feel from 536 reported cases to 11 million reported cases, this has been an obsession of looking at this data every day. So we were concerned about India. India has some advantages. India's population is very young. 40% of India's population is in the age group of 0 to 18, and where we know the incidence of SARS-CoV-2 infection is quite low. And so, and again, but we are concerned about India because the healthcare infrastructure in India is quite fragile. Large number of uninsured people, large number of people with comorbidities which have been associated with COVID-19, as well as very few ICU beds and COVID care centers at that point of time. So India also has 1.37 billion people. So it would be, so in our mind, like, if it exploded in India, this would be a real catastrophe. So this was our first set of projections. We compared India to United States and Italy and predicted the virus trajectory. And the point estimate, we said that, yes, we are here in March 16th with 500 cases, but by May 15, you may as well have 60,000 cases. And the prediction interval, I just want to be honest about prediction interval and prediction uncertainty, was about 900,000. So I realized that credible intervals and prediction credible intervals, this is my lesson number 1 from this process, is uniformly misunderstood by non-statisticians, and policymakers tend to report the lower credible interval, saying that everything is fine, and journalists and media tend to quote the upper credible interval, that everything is going all right. So next morning, we absolutely had no idea that this Medium article would be picked up by media all over the world, as well as the report that we had published, because at that point there was not like there were hearsays, but not really a scientific model with concrete projection, with codes, a publicly disseminated model. And so from Reuters to Guardian to BBC, and it was very nice, I have to say, to see a picture of 2 women data scientists on the pages of Times of India. But it was very scary. It was very unnerving, because we as statisticians work behind the scenes most of the time. It's uncomfortable to go on television or being interviewed. It was really difficult. So within 3 days, we had to revise our projections, and data on the ground was changing very rapidly. That 60,000 point estimate became 97,000, and the upper prediction intervals shifted to 1.3 million. So this was March 20th, and on March 24th came the decision for India's national lockdown. One of the most controversial policy decisions in the history of public health, and as well as the nation, for India to put 1.37 billion people under lockdown with a notice of only about 3 to 4 to 5 hours. So a tragedy unfolded. I do not know how many of you followed what happened with the migrant workers in India, because they come to the cities for their daily work, livelihoods. And then when the lockdown came, they wanted to go back to the villages, but there was no adequate transportation. A tragedy unfolded, and the whole goal was to put the population at a static time point, but with all of these movements, some of the transmission, arresting the transmission was not possible. So a lockdown, we are going to talk about lockdown in terms of only controlling coronavirus related cases and deaths and hospitalization. But there's a whole bigger connotation, which we all recognize, on human life. And to be involved in your statistical models in such a decision is really nerve-wracking. There were lots of social implications of the lockdown in India. India is a very social country, coming joyfully together. Here you can see that there was a day where candles were lit all across India to display a feeling of solidarity. And this decision of lockdown and unlocking has been debated, like in every country, in India as well, and it has become very politicized. And so since then, we have been modeling the pandemic, and we never stopped because of actually our app. Our models get updated every day. So it became a go-to place for epidemiologists and also journalists. And since then, I think there have been more than 1,100 media clips reaching a view of 6 billion. And so, we write a lot of papers, but starting with the Medium article at the right time and then growing this work, this has been really very, very surprising to all of us. So models, coming back to models, and the models for India, just like any other place, have been growing as exponentially as the virus. And I apologize if I have not listed all the models, but these are some that we compared our modeling with. So what we used at that time, in the beginning part of the pandemic, we used a very, very simple model. We used a SIR model, a state space model, which has only 3 states, the S, the susceptible compartment, I, the infected compartment, and removed, which is removed from this infection in the dynamic transmission system, from which contributes both recovery and death. So these models are good for modeling transmission using count data. The problem is that you do not really know the true proportion or the prevalence at a given time t in each of these compartments. So this is a model my colleague Peter Song had proposed an extension to. And you can see that in their work, they call it an extended SIR model, where you have these three proportions, these three latent Markov process, prevalence process proportions of each of these three compartments at time t, theta s, theta I, and theta r, that you do not get to observe. These are latent variables. And then you get to see the reported counts, which are the y's. And then it moves to theta t plus 1 following some transmission dynamics, which I'm going to come to in a moment. And you try to write down that dynamics, and you try to write down the likelihood as well. So there are two components to this model. And if you're interested, they have a wonderful ESIR package on RCRAN that you can use. And Peter and his student Lili Wang were incredibly helpful to guide us through modeling this in the in the 3 or 4 days when we've had the first set of projections. So as I said, that from each compartment to another compartment, how you move is controlled by a set of differential equations. And these are really in terms of how many people, at what rate people are getting infected, and what rate people are getting recovered. Those are the beta and the gamma are those two key parameters that you have in these differential equations. And as I said, that these are unusual type of formulation of in a statistical model, because we do not see a linear y equal to x beta structure. And this is one class of models. And then in order to incorporate some stochastic framework to it, you assume that the observed proportions conditional on the true latent proportion have a beta distribution. And the lambda parameters actually control the variance of that beta distribution. So once you have this latent three-dimensional prevalence process, and tau actually denotes all other parameters. So then you want to build the autocorrelation in this process from time t to t minus 1. And what you do is to really solve this system of equations to bring to the systems lead to a function f, where you can solve and you can write down that mean of the Dirichlet distribution. And kappa is the scaling parameter for the Dirichlet distribution. So basically you have a compartmental specification, and then you have a Dirichlet distribution, which is building the autocorrelation. And the parameter are not that we have, or are effective, that we have talked about a lot. The basic reproduction number is actually a function of the parameters beta and gamma in this model, which is beta over gamma. And the reason I'm mentioning this, because it's much easier probably to generate a prior distribution on R0 from previous data than about the transmission infection rate or the recovery rate. So essentially, and again, I'm not going to go to the very details because this is something that Peter and his group did. The advantages of this model is that you can characterize the uncertainty. And then we developed, and this is a beta Dirichlet, easy to draw from the posterior. And once you do that, the advantage as opposed to a deterministic set of equation is that you can get the entire distribution, posterior distribution of beta gamma and this R0, this basic reproduction number. But what you're interested in is probably not just the beta gamma in prediction or forecasting from time t plus 1 to t over a period, what the counts or the virus incidence curve or the trajectory is going to look like. And you can do that as well. You can draw posterior distribution, the predictive distribution of the y's and the thetas as well. And you can project it. So using observed data up to a certain time point, you can project at future dates. And you are interested in what proportion in compartment I, in compartment R, and also you can create a projection for the daily incidence curve. And that's where things come, where the curve is going to turn, where is going to be the peak, where these compartments are going to be maximized, All of these things can be calculated, guided by that engine from which this stochastic process is emitted. So that's the general idea of this model. And then again, you cannot have a closed form solution for this system of equations. So we used an approximation, the Rangakuta approximation, in order to derive this, this mean function as a function of the previous day. So when you estimate, you have the beta parameter, you have the gamma parameter, you have the lambda parameter, and then you have the kappa parameter. These are what you see. Then you also have theta naught, where the equation or the system starts, which you can start by assuming some state initial day counts, use that as a raw estimate for theta naught. So yes, yeah, sure.
The question, so the question is in your model and how you can consider incorporate the undercounting of the COVID-19 cases.
Yeah, I'm going to come to that in a moment. So this model did not have that. This model just had the latent parameters. I'm going to come to the extension. So please just give me a few minutes and I'll come to that question. This is very important. So, so the modeling, the interventions in this model is basically saying that I'm going to introduce some intervention, just like face covering or travel ban or national lockdown, through which I believe that the probability that the transmission was happening from susceptible to infection or infection to susceptible, that probability of a susceptible person meeting with an infected person and getting the virus, that's going to come down. I'm going to block that path by introducing interventions. So, and each kind of intervention, mask covering, social distancing, travel ban, will have some kind of reduction, which we hope in this probability. At that time, we did not really know what this pie is going to look like for different interventions and for national lockdowns. So we borrowed as much as we could from actually Shihong's paper analyzing the Wuhan data, that what would be the effect of the interventions, and then built uncertainty around it. So how to estimate this pie, the effect of the intervention, there is much more data now in the world, but as we did it, we took it as a very simple step function as India introduced different types of intervention. You can also have a distributional model for pi as a function of t as well. This is an interesting question that we can come back to. But for the policymakers, what we had to produce are curves like this, that what is going to happen if you have social distance plus travel ban, how is the incidence, the new cases, daily new cases is going to look like? How, if we return from the lockdown in a cautious way with masks and social distancing, how is the curve going to look like? And then how is the curve going to look like if we have a cautious return but moderate return? So these are some of the things that you sort of create these probabilities in your head. And at that time, it's all like, conjecture that by how much is it going to reduce. And we also show that if you come back, return to normalcy in a very overzealous way after the lockdown, you'll negate the effect of the lockdown. And similarly, there were questions about what is the length of the lockdown. And this is a very tricky question. And even my parents were saying that, can your models tell you that it is 3-week lockdown is enough? But we also produced curves which showed that a 5 to 6 to 8 weeks lockdown was better, qualitatively better in terms of a 21 or 28-day lockdown. But again, these are like conjectural values that we are putting there. We did not really know much about, we are writing the playbook as we go along. So there is this controversial question that whether the lockdown was effective in India, or particularly in a highly populated, low resource setting, is this possible, like really densely populated? So you can see in this graph what happened with the lockdown in India. So the lockdown was lifted on May 31st, and the virus curve in India kept going up and up and up until September. And I'm going to talk about that in a little bit. And so did it really help with reducing the transmission? So much suffering of cost of lives and livelihoods, was it worth it? So that's a decision and a discussion that we are going to debate for a long time. But I want to show you one thing, that in the government of India, we often forget to give credits to countries with low resources who have done an amazing job in scaling up healthcare infrastructure. I want to show you this slide that even though not transmission is not the only point, building up healthcare capacity, particularly for a country like India, was incredibly important in terms of how to take care of the COVID patients. And you can see that from March to the end of 2020, what has happened in India, the number of tests per day has scaled up from of the order of 3,000 to 1 million. The prices of diagnostic tests have come down to $3 or $4. ICU beds have been threefold. Isolation beds, these are COVID care centers that the Indian government created. This has wonderful facilities. Actually, when I was in India, I took a look at one of them with good food and care for people. This was incredible. And also COVID care centers from 2,000 to 15,400 COVID care centers all around the nation. You needed that time in order to cope with the virus. So I think that they're aware you cannot just evaluate the lockdown only in terms of COVID cases or transmission. You have to look at the holistic picture. So we wrote a paper on the evaluation of lockdown. And then came this next part in terms of updating our model, that how can we keep this work going? Because unlike any other statistical work where we write our paper, the reviewers take 6 months to review, and then you don't touch the paper, and then you run your models. That's not how this work was supposed to be. So we quickly realized that if you calibrate your model with the data on the ground and run it every day, then we get much better prediction. So I think the only contribution in this work was not about writing papers. This work was initially not about developing new methodology as well. It was about getting the data analyzed in a rigorous framework and disseminating it. So what we did was to figure out an automated way how these models are going to run every day without anybody touching it. Because it's not possible for a GSRA to wake up every morning and run the model for India and all of its states. So that's what we were able to do to update the model every day. And I'm just showing you New Delhi because if you just ran one model without tuning the parameters, it cannot really capture the features of the virus incidence curve. So this is New Delhi, and I'm just going to show you sort of like a movie, what happened in June and July, how things changed, and you have to adapt to these features. So this was in June, this was in August, and then people get tired of the intervention measures, and then you see a peak again. And then you again intensify your measures, but then comes Diwali or the festival season, you see another peak again. And so this is something that you have to run every day in order to capture this multi-modality and the peaks and what's happening with the data on the ground. So now we come to the methodological part. And as so far, what I have shown you, there is nothing beyond taking a software, implementing it rigorously in real time and building an app. So then I went to a talk show, and it's very interesting that you get an idea at a talk show. This was an interview with Karan Thapar. He's one of India's most regarded journalists. He's like the Anderson Cooper of our time. I grew up watching him, so I was extremely flattered and very nervous to talk with him. He was extremely pushy, and he asked me questions, and I was really criticized for saying that there is a lot of underreporting going on in India. And though you were reporting so many cases, India could have much more. And right now India is reporting 11 million, but there could be a lot more asymptomatic cases or covert infections. And I said this number based on some work that we are doing, but I was really criticized in the media for these high numbers. So this work, and this addresses the question of how do you estimate the number, the estimated number of asymptomatic infections or unreported infection. This was also the work of two graduate students from Indian Statistical Institute who were supposed to come for an internship to Michigan, and they really could not come. So we continued to meet on weekends and in the evenings to talk about a more finer compartmental model, which does more realistic, in my opinion, to what was going on with testing in each of the countries, as well as the false negative of these tests. So in this model, we actually introduced a compartment so that you have tested and also you have unreported infections as a compartment. And so by using this model, I'm going to show you the details of this specification, because to me, it always seemed like I'm committing a statistical sin by plotting this reported counts across different countries and different systems on the same graph, because access to testing, priorities for testing are so different across the countries. So the underreporting factor for India, we estimated always throughout this whole period for cases, 1 out of 10 to 1 out of 20 cases were being reported. And for deaths, 1 out of 2 to 1 out of 5, depending on where you are. And that gives you an infection fatality rate, which I'm going to come in a moment, which is much lower than the case fatality rate that you see. And it's lower overall across India compared to what we have seen in rest of the world. It's on the lower side. But even then, even if I believe the lowest end of that infection fatality rate, if 50% of India gets infection, we'll have about 670,000 deaths. So this is the more sophisticated model and an extension of the compartmental models, where we try to take care of the false negatives and the false positives of the test, saying that the false negatives can give you a false security, and you go back to the unreported cases and how you can incorporate sensitivity and specificity of the test and the selectivity of the test. So selection bias and misclassification at play here when you look at the counts and how you can incorporate that. So that led to some interesting work about estimating this underreporting factor and the true infection fatality rate in India, because now you can come up with the case fatality rate, which is just observed death to observed cases. And then if you believe that there is underreporting of cases, then you change the denominator. And if you believe that there has been underreporting of deaths, you change the numerator as well. So you can see that we created this IFR estimate for India under different circumstances, as well as all of India's states. And then we also created this underreporting factor for India and all its states to show the distribution, that which states are doing well in terms of testing and which states are not doing so well. And there is a lot of misassignment of deaths in India. There has been validation studies. This is incredibly hard to get data on, like historical data on case series on deaths in India. But there have been studies mining obituaries, crematorium records, which shows that there has been a lot of underreporting of deaths or misassignment in terms of the causes of death as well. So this was the second part, and I was really thrilled when we saw that what our models were telling us. The sero surveys, India has done an incredibly good job with doing longitudinal reported sero surveys nationally, as well as in some states. And what you see in India is a striking phenomenon that in urban areas and dense population slums, you have about 50 to 60% people already infected, already have the antibody. So, and the national survey says there is a lot of this difference in terms of rural and urban India, but 21.4% people have the antibody from the national sero survey. So that will give you about 175 million infections in India right now, when we are reporting 12 million. So we are only seeing the tip of the iceberg. And then qualitatively, it agrees with the model estimates. I think there is a little bit of overestimation in sero surveys. That's a talk for another day. But I think that this is the high degree of covert infections. You cannot deny it. So there were methodological advances coming through that initial kernel of an idea, and we develop an R package, ACIR Fancy, which takes the false negative and the symptomatic distribution of tests in terms of both selection bias and misclassification. And then we also worked on optimal test allocation strategy, comparison of models, but they came much, much later than the initial modeling. And when we are doing all of this, as statisticians, we really are very careful, and that's our strength. Now we are pushed to a time when you have to do research real time, and this was unnerving. And one day in July, one of my friends texted me that, Brahmar, your name was quoted in a New York Times op-ed by Michael Eisen and Rob Tibshirani. And I opened my New York Times app and saw the title of this article, How to Identify Flawed Research Before It Becomes Dangerous. And I just thought, you know, I'm done. Maybe I made a mistake, and mistakes can happen because we're doing such rapid work. But this will remain one of the most reassuring and rewards of this time that Professor Eisen and Tibshirani really mentioned our work as an example of a rigorous science done in a nimble manner. So this was a huge honor personally. So where is India now? I'm going to wrap up soon. That India, the curve has turned the corner. You see a slightly uptick. And so everybody is wondering about the peak of the projection for the second peak. And again, testing has scaled up, 2.5% daily positive rate right now. It went below 2% for a long time. Now you can see a little bit of uptick here. So at one point of time, it looked like India is going to take over. So if you look at this time point, it's going to look like India was going to take over in like late August, early September. But you can see what has happened. We see a drastic drop in US as well. In India, where is it going to go? We see a little uptick, and I find it really challenging to model this right now because we know the serosurvey data. So if I assume those 50 to 60% in the urban areas cannot get reinfected, I get a completely different kind of projection than incorporating that, yes, they can get reinfected, maybe disease-induced immunity is waning, or they're getting reinfected by the new variants. We also do not know what fraction will be vaccinated in the next 1 month in India. So what our models project is really damped oscillations, not a huge second peak, because it really depends on what assumptions you make. The statistical models are really wrinkled with assumption, and nobody knows what is going to happen on the ground with vaccination and this reinfection quantity being big unknowns with these projection models. I'd be very happy to discuss and listen to your thoughts on this. And again, this is something that we produce in the app, that the effective R over time, and after staying below unity for a long, long time, it has gone above 1 again. And this is one snapshot that we produce in the app, which has different public health metrics in terms of the basic reproduction number, the effective reproduction number, the case fatality rate, the test positive rate, and our 3-week out projection. And I learned that you have to really synthesize all of this information so that someone could actually print a page and take it to a meeting. So I think these were some of the learning lessons throughout this whole 1 year. So moving forward, I think some of the lessons that I learned, that it would be really audacious to say that my model is best than all other models, or any claim of novelty or supremacy here. You have to proceed with humility. Ensembling different models have different strength. Ensembling is a better alternative in our experiment. We really need a transparent vaccine dissemination plan for India, and public-private partnership is really scaling up. I'm very, very happy. The pandemic and the lockdown really caused a lot of disruption to normal healthcare, nutrition programs, immunization, educational infrastructure. So I think that India has to evaluate this pandemic in a more holistic way, and like all rest of the world. India has done a fabulous job in doing this national serosurveys, and I think it's important to keep doing that to understand what's going on with vaccination. And I think that historical data, the data deficient environment in India did not help in characterizing excess deaths, because deaths from accidents or other infectious diseases have also gone down. So how do we quantify that? There has been a national effort for recovery, just like in the US, for the long haulers as well as the post-COVID syndromes. The final thing I want to say, that throughout this whole process, I think we realized in sitting in the School of Public Health that the public has a serious role in public health. We need to manage risk in our daily lives. And I want to show you, this is a paper in Nature and JAMA, which ranks all the activities in terms of the risk. And you can see that some of the things that we love, getting together with friends, going to a full service restaurant, they are the high risk conferring activities. So we have to manage risk in our daily lives as individuals. And this is really important, that human beings can trump dire model predictions, and human beings can also change the model prediction. So what we have seen in the 2020, 2021 is a quartet, string quartet, not always in harmony between the governments, the public, the scientists, the corporations, and the silent conductor, the virus. I want to end on some humanitarian component, because this has been a really stressful time for all of us, and it's also has been a very time to reflect. I want to show you this public health guidance from 100 years ago during the 1918 influenza pandemic. Some of those recommendations are still the same. Do not neglect your mask. And the second one I found very interesting because we have seen over and over a replication of this theme. Do not disregard the advice of a specialist just because you do not understand. So we are all, it's a long haul, we are all tired, but I think that there is something, recommendations are eternal to society and history. We need to really think about the mental health and humanitarian aspects of this pandemic for years and years to come, some quantitatively, some qualitatively. And I really enjoyed this paper as the chair of a department and really thinking about our students through this time, thinking about education through this time, that we have to lead with science and we have to lead with humanity. This paper in Nature Cancer was a beautiful articulation of this theme. I want to show you pictures from India because it's a low resource country. You see one of the world's largest slums where social distancing is a unacceptable or infeasible concept. So still what India has been able to do, you see women in India, they don't have KN95, but they all have face covering. They don't have access to a large number of tests, but community health workers are doing syndromic surveillance, checking temperatures of people. So I think that we really have to think about, and the Indian government has been very consistent in terms of messaging that this is a really serious crisis and everybody needs to do their part. So I want to end on a more poetry note because I grew up in a family of liberal arts people. One of my favorite poets is Rilke, and this poem says that let everything happen to you, the beauty and the terror, just keep going. No feeling is final. And I think that this time has really taught us that no feeling is final, that things are moving in cycles, and that's how history is supposed to be. This picture was taken in my home state, West Bengal. A man in the middle of the pandemic, the state was hit by a very bad cyclone, but this man is upright and still walking. And that is an image that I carry within me, in my heart. On a more personal note, in terms of managing our personal risks, I used to look at, like, for the whole 6 months of the pandemic under lockdown, I used to look at my parents' picture on my desk in Ann Arbor. And then finally, I had to take this decision just before the US elections. I flew back to India. You can see me as a poster child of public health in hazmat suit and goggles. And then I was reunited with my parents, who were really in a very depressing mental state. And that will remain the most important lesson for me during this time, to be reunited with my family. And really, when I left, my parents were much more hopeful with the vaccination, but we cannot really decouple our personal and professional self. And this has been a very, very enriching time for me in the landscape of statistics, learning so many things in data science, but also in the personal front. So thank you for listening to my story and the story of India. I wish you all safety, health, and vaccination.
Thank you, Bamar. It's a great talk. I'm actually encouraged of what we can contribute to our society. So now let's come back to some of the questions in the Q&A. Someone is actually asking you comments on the spatial distribution of the data and sensitivity analysis on these estimates. Do you have any comments?
Yeah. So, you know, as I said, that one thing I did not mention is that when our first model projections were just taking India as a whole, because we had only 500 cases. And so taking India as a homogeneous system was not the right thing to do statistically. So as we had more data in our app, you'll see that we have models for every state. India is really a nation within nations. And the reason that you could not see the peak in India for a long time was because now, unless every state, every major state came to a state of containment, you could not really see the peak. So in our state-specific models, we have a much more granular information. But in the beginning part, we had to go with the simplest, and then we built complexity. It's incredibly hard to get mobility data uniformly across India. And also it's very hard to get age and sex specific contact network, which is a key thing that you can incorporate in these models. So we did as best as we could, and you can look at our models for the different states. Lily, you are muted.
Sorry. So another question is asking your thoughts on the CFR and IFR in India.
Yeah, I think I showed the slides with respect to that. I think the case fatality rate is around 1.4% right now. And then the estimate of the IFR by any kind of statistical model or serosurveys will give you around 0.1%. And if you take the underreporting of deaths into account, you get 0.3 to 0.4%.
Okay, thank you. So the next question is, what are some common and distinct features of modeling the data from India and the US?
This is a great question. So I think that one of the advantages of modeling the India data over time was really pinning down this number of asymptomatic infection with the information from the serosurvey. So you could actually say that, of course, it's based on the assumption that people who have antibody cannot get reinfected. And again, that may not be true as time goes by. But this longitudinal repeated serosurveys in India had really helped us to tune that parameter in terms of who are in the susceptible compartment. And I think that's one of the reasons the virus curve turned the corner in September, because a large number of people in major metros and highly populated areas were already infected. And without knowing this information, I think you could never get to that point. So I think that was very helpful, which I don't think that we had in US. And in US, I have not done any kind of projection modeling for the daily time series, but having access to the individual level data has been fantastic in terms of the United States data, because we have the electronic health records and different consortium. Individual level data is very critical in terms of comorbidities, past vaccination. We just don't have that for India. So I think these are the two things that jumps at me right now.
Okay, thank you. Are you planning to implement your model for the American data, for the US data in the future?
So one thing which was a little bit nationalistic for me was that, India is always criticized for its data infrastructure, and I share some of that criticism, but you cannot really give up. You have to do your best method with the most imperfect data, so that I don't think that we can strive for correct inference. These days, I always strive for less incorrect inference. So I think that the less incorrect inference is what we wanted to do. And there are wonderful models for as I said, that this was done as much more of a team building exercise. And there are wonderful models for the United States. And I don't think that we need to duplicate our efforts. So, and you need subject matter, like you really need to know the context in order to build these models. And I think that the epidemiologic model part, I'll restrict to India, and then doing the EHR work, what I'm familiar with, I'm going to continue to do in the United States, I and my team.
Okay, thank you. So another question is about modeling. So I saw in your model, you mentioned you can model interventions, right? So right now with the vaccination, and I'm wondering how the model can incorporate the vaccination.
Yeah, that's a great
different type of vaccines, right? There are messenger RNA vaccine and also a virus Johnson vaccine.
Yeah. That's a great question. So there are two things that you have to get a data on. So you can modify in terms of your rates. So the vaccines, initially we had data on hospitalization and severe disease and symptomatic disease. We really did not have much data on how much it reduces infection or transmission, because that's needed as you think about that pie, which is blocking the susceptible to infection, right? And then you have the hospitalization probabilities and the recovery probabilities there you can incorporate. So how you model those probabilities, who are in your, what fraction of the population is in your susceptible compartment, and that those are all important information, and the data on infectious, whether you carry the infection or transmit the infection, is coming out, and it's looking very promising. So I think that as we gather more information, we can incorporate that into defining the parameters and who are susceptible, and with all of those parameters in the transmission and the recovery compartment.
Okay, thank you. So the next question is, when we publish papers in a statistical journal, it takes several months or maybe even a year or longer to get it published. So how can statistical journals publish impactful COVID work in real time? Because you mentioned like the timing is very important. So do you have some comments or suggest thoughts on this?
So I think that, we as a community need to really learn how to reward and recognize different types of work. As I said, that the initial work was definitely, I did not think that we are going to publish this work, because it is really taking the software that Peter's group had developed and applying it to India and tuning some of the parameters with respect to the Indian context. So from a methodology point of view, the contribution of that is really incremental. But as you do the public health communication and you implement a model rigorously and sort of keep doing it, it becomes significant, right? It's not from a methodology point of view, it's from a public engagement point of view. And I personally feel this whole 1 year was very different than any of the other years, where you really are interested in the questions and what is happening to India, because everything that happens is related to how my loved ones are going to lead their life or how I am going to lead their life. So it's very hard to decouple that. And it was a very different kind of time. And we need to recognize, I think, as a department chair and as a researcher, I feel we need to recognize these different types of work. And then maybe I am actually really proud that we are so rigorous and careful as a profession, that then the methodological paper probably will come out later with much more clarification and checking and refinement. But to get the message out there in a good way, not maybe the perfect way, is also important. I think we need to really and then you look at all of the methodology that have come out, which has been incredible as well.
Okay, so there's a question from Xi Hong, and she's asking, what can we learn from the experience of the implementation and the messaging of public health intervention from India?
Yeah, so Shihong, that's a great question. And I think that as we model the data from as US and India, Lily asked me what are the differences. I only talked about in terms of data. I did not talk about in terms of the policy or the polarization. I think one thing which was really helpful for India was this consistent messaging from the government that this is serious, and the national lockdown, though controversial, sent the message that this is an incredibly unprecedented time. What in terms of the prevention measures, I think one thing which was really important for India was centralized quarantine and isolation. As I showed you the picture of the slums, it's not possible to do social distancing in a household living with 8-9 people, and cluster infections are going to happen. So to really pull out the infected or the symptomatic individual in a facility, in an isolation center, was really helpful for India. And the other thing I think is testing. India really scaled up testing. I was in India for 2.5 months, and I can honestly say getting tested and getting the results in India was much easier than getting tested and getting the results in Michigan, where it still takes 2 or 3 days to get an appointment and to get tested. Now it's different with the home testing and everything. So I think the public-private partnership and how to really mobilize community health workers when you don't have tests. What is your alternative? Low resource settings have different alternatives than a high resource setting. So there are lots of little clever things that were done at a very grassroots level. This is something to definitely learn from.
Thank you. Sorry, we're running out of time. So thank you all for attending, and I hope you all enjoy the webinar. Bye-bye.